Okay. Well, welcome everyone to this very informative and inspiring session on CAPABLE, which stands for Community Aging in Place, Advancing Better Living for Elders. We're delighted to have Amanda Goodenow, the Strategic Partnership Specialist with the CAPABLE National Center, join us today. Amanda is a very dedicated occupational therapist who continues to work with older adults to help them to gain more independence and autonomy. She provides clinical support at the Colorado Visiting Nurses Association. She has a Master of Science in Occupational Therapy from the University of Central Arkansas. And for years, Amanda worked in hospitals and traditional home care. But it's a testament to her commitment to older adults that she made the change to working with CAPABLE and supporting person-directed work with older adults that's empowering and life. From Amanda to tell us more about CAPABLE and how we can help to advance this important work in Canada. So welcome, Amanda. Over to you.
Hello, yes, I'm Amanda, and I'm here to share about CAPABLE today. And I would like to start off first with the video. So, Harry, if you can pull up the slides and.
Okay, good.
Our population is aging. And as we age, we spend more and more time at home. Our home is our sanctuary, but it can also be a real burden as we get older.
Without the ability to stay in my home, I would feel, wow, very sad, demoralized, yes. I would feel useless.
We have so many older adults who are aging in place, and they want to remain in their homes, but the problem is their physical function limits them from being able to remain there safely and independently.
How do we address that? How do we help these people age in place in a way that is cost-effective and meaningful for them? CAPABLE is the perfect solution. We help the clients help themselves. So the CAPABLE program, Community Aging in Place, Advancing Better Living for Elders, strives to help people age in place better and more safely.
Intellectually, I'm still very capable. My body's stubborn. This doesn't mean I'm quits. There's a dignity to living on your own as long as you can. That dignity gives you more self-confidence. My attitude, my emotions, my mental health. That starts with dignity and feeling safe in my own home.
That's what I want. That's also the concern of my family, to be safe in my apartment.
They don't want to have to live in a skilled nursing facility. They want to be close to family, close to their community. And with some simple interventions, we can allow them to do that and allows them to live happy, fulfilling lives.
What makes CAPABLE unique is, I think, first of all, that it's a team approach.
So we're going to review the brainstorming sheets.
The client runs the show. The participant is the person that lets us know what's meaningful for you and what interventions will you most likely employ.
The concept of CAPABLE is very simple. It simply provides a registered nurse, an occupational therapist, and a handy person to go to an older adult and ask them what they would like to achieve in living in their home. And they work towards that, and it makes it happen.
They had a handyman who came in and made my home more physically safe for me by adjusting threshold crossers, the safety grip bar in the bathroom shower, and these grabbers that allow me to grab things from way in the back that I can't reach anymore. Then we've got my blood pressure cuff, a reliable wrist one that allows me to take the readings my cardiologist needs on a daily basis. That and the handyman fixed my elliptical.
What CAPABLE really gave me, first of all, is the confidence of safety. Because that's what I'm scared, that if I fall, that will start the downfall of my health. My legs are not strong, but with the help of this dumbbells and this bike make me more stronger.
You know, we look at older adults who've enrolled in Capable and compare them to ones who haven't, and compare their health insurance claims. And what we know is that the older adults who get enrolled in Capable, their healthcare costs are less. Insurance providers pay less money for those clients because those older adults have agency and hope, and they've improved function and they're less depressed.
This program is about prevention. We've really shown that a small investment in the individual can save tens of thousands of dollars in medical cost. So we're talking about our high utilizers. You know, the older we get, the more health care we utilize, the more costs we rack up. So anytime we can prevent a fall, we save the system money. And in my view, saving the system money also means saving the client suffering. It improves their quality of life.
And it's really unique. It's different than a doctor writing a prescription. It's giving the person a sense that they can change their life.
I am really very capable, and I'm capable because I believe in myself. I'm capable because others believe in me. And I'm capable because I can find ways to get things done, maybe differently from the way I used to do them. I'm just as capable as I was when I was 30. I'm just capable in a different way.
Pulls my strings every time. I've seen it a ton of times also.
Okay, I think your sound's a little muddy. Harry, can we make the sound a little clearer and just go to the slides and Amanda, please?
Oh, can you hear me better now?
Yeah, maybe turn your volume up a bit, Amanda, and see.
Yeah, your mic's a little muddy.
Yeah, so just turn your volume up. That'd be great. Okay, I think we're good.
That's better? Okay. I was just saying how that video gets to me every time. I've seen it a ton of times. So I love that video because it does provide a great perspective of the client's experience in the program. As mentioned, this program is an evidence-based program out of Johns Hopkins School of Nursing. There's over a decade work of evidence supporting Capable. And so I'm excited to share this program with you today. Next slide. So Capable is all completed inside the home. So all the visits that are completed by the interdisciplinary team, that includes an occupational therapist, a registered nurse, and the handy worker, all occur inside the home. And as mentioned in the video, it is client directed. So the client picks out with the occupational therapist and with the registered nurse the things that they want to address, the things that they want to improve in, try to increase their independence and safety in, or try to increase their knowledge in. The program has a long-term impact. Because of the methodology that is used to implement Capable, the clients learn how to problem solve and brainstorm issues that come up that make everyday life easier. And with this methodology, they are able to use these steps and these techniques once the program is over, which continues the impact on their life. And that's where the research comes in and shows how it decreases hospitalizations and ER visits 2 years post-intervention. But it also provides this behavioral change. Our individuals no longer feel stuck in life. They no longer feel like this is just the way it's supposed to be. This opportunity to have that self-efficacy and that empowerment to make change as things do progress in the aging process. Next slide. So how Capable works, as mentioned before, you have an occupational therapist, a registered nurse, and a handy worker who work with the participant or the client that wants to participate in Capable. The client picks out the goals. So the clinicians have assessments that are prefabricated for them, but they're all open-ended questions, asking the client, how difficult are things for them? What do their daily challenges look like as examples? And then the client has the opportunity to answer or not share. It's completely up to them, but it's all up to the client. We provide an opportunity for the client to participate and answer questions as they feel are relevant to them. Next slide. This is what the program looks like over that 4-month period of time. Click. The occupational therapist goes out and completes a capable assessment. We're asking questions related to related to functional mobility, activities of daily living like dressing, bathing, toileting, and then our instrumental activities of daily living, which include cooking, cleaning, and laundry. We're asking very detailed, specific requests of how difficult strategies. Out of the items that they identify as important to learn new strategies, we then take those and ask them to narrow those down to their 3 goals. So the client then picks out the 3 priority areas that they want to improve in and increase their independence and safety. Next. On the OT second visit, we take those 3 areas and we do a home assessment. We determine what things need to be completed or purchased to help the client reach those goals. Within the capable model, what's great is things can be purchased that are everyday tools and equipment. So it doesn't necessarily have to be a medical related piece of equipment. We have the opportunity to, yes, buy medical equipment that isn't covered by insurance, but we also have the opportunity to buy things like a can opener if they're having difficulty opening cans, or an anti-fatigue mat if they're having a hard time standing for long periods of time to cook. So within the second visit, we address the goals. We look at what things do we need to purchase or implement to support the goals. And then we look at the whole house. If there's room within our budget, we also list items on the work order that can increase the client's independence and safety. And we put those on a work order. Next. That work order is then sent to a construction specialist. Each site here in the United States, along with our site in Nova Scotia, have a partnership with a construction specialist or a handy worker or handy person. Those individuals review things that we can implement within our scope of work, and then they call the client and set up an assessment time. This assessment is just to make sure that if I'm requesting for a grab bar to go somewhere in the shower, that there is a stud behind the wall to support that grab bar. Then, once they've determined that the items on the work order are feasible, they fit within our budget, then they will order the equipment and then set up an install day at some point within this 4-month intervention. One thing to point out is that each site has their own modification budget. So as the Capable National Center, we do not dictate what the home modification budget is. However, it does range anywhere from about $1,300 to about $2,000 here in the United States. But again, each site gets to determine what that modification budget is for them. Next. After the OT second visit, then the nurse goes out and completes their capable assessment. They're asking questions related to comorbidities, pain, mood, nutrition, sexual health, falls, exercise, those kinds of topics. And at the end of each subject, they're asking, is this something you want to dive deeper into, improve in, learn more about? And again, from there, the client formulates 2 to 3 goals with the nurse. You can click through a couple of times. After the goals are set, the visits are then every 3 weeks. We address 1 goal at a time. So on the OT third visit, we're going to address the very first goal that the client picked out. On the RN second visit, they're going to address the first goal that client picked out with them. But instead of going in and telling the individual what they need to do to reach their goal, what's causing the issue? Why are you not at this goal yet? And then from there, after we list out the reason why the problem's occurring, we then ask them to figure out solutions to make that goal more obtainable. So, for instance, let's say the client's goal is to get in and out of the shower with less fear of falling. We are then finding out, I'm fearful of falling because I have nothing to hold on to. The lighting is poor, the bathtub floor is slippery, or outside of the bathtub is slippery, things like that. Instead of saying, okay, well, you have nothing to hold on to, let's put a grab bar there, we're asking, there's nothing to hold on to, what would be helpful? The bathroom floor is slippery, what would be helpful? So we're having the individual come up with the solutions themselves. Sometimes it's just a conversation that we're having. They'll say, the bathroom floor is really slippery and I need a grab bar to hold on to. Great, so I'm going to write down a grab bar as a solution. But what might help out that floor from not being as slippery? And then they're coming up with the solution. Maybe it's anti-skid strips. So again, on each visit, and you can click through a couple of more, each visit we're addressing one goal at a time, but using this same methodology of breaking down the problem and trying to come up with solutions for the problem. Click 3 more times. So overall, the client will address 6 goals, 5 to 6 goals with us as clinicians. And so they'll have that opportunity 5 to 6 times to use that method. This methodology for that future problem that comes up. And again, at some point during this 4-month intervention, the home modifications will have occurred. Our handy person will have gone out and completed the modifications. It is up to the occupational therapist to address those modifications, to make sure the client is safe using them and make sure they have no questions and concerns regarding them. Often people will have grab bars installed. However, they don't necessarily know how to properly use them as far as how they're reaching for it and making sure they're not putting their shoulder like at a weird angle. So it's really important after the modifications are completed that the occupational therapist observes them using it and making sure that they're safe. Next slide. We now have an adaptation to capable so I just showed you the traditional capable, and now we have an opportunity to where if a client has a caregiver or a care partner, that care partner can also be supported within the capable model. So caregivers and care partners are very crucial to our aging population. However, there haven't always been the best supports for those individuals. And so burnout is an extreme issue and concern. Within the capable model, we do now provide an opportunity to where a care partner support specialist can be part of the model. This is an opportunity that if there is a caregiver or a care partner involved with the client, that they can have support by our who is highly educated in providing caregiver resources like a social worker. They have the opportunity to meet with that caregiver, ask them what concerns they're having. They do provide an assessment with that care partner or caregiver, and then there are 1 to 2 visits later with that individual. This is outside of the capable model with the client. So this is just with the care partner. So it gives them some support in the role that they have with our capable client. Next slide. So the capable participants, we often get asked who's eligible for capable. And again, that often depends on the site as well and who's funding the program. Our research, however, is for people that are 50 or older. The initial research was 65. We have recently lowered that age to 50 because we did find people that were 50 and older did have some higher hospitalization rates and rehospitalization rates. And we found that people who were 50 or older also benefited. So even though they were in between that 50 and originally 65 age, they found that the benefits of them participating in capable were well established, and it was nice to have that population added. The clients also need to identify that they have difficulty, meaning they to have arthritis. We want clients who say, you know what, I have arthritis and I know it's not going to go away, but I would really like to be able to get my shoes and socks on easier. Or I'd like to be able to garden with less pain. So we want clients that identify that they have difficulty and that they want to improve in it. They also need to be living at home or in an apartment, meaning they're not in that higher level of care yet, like an assisted living or a nursing home, because that is what we're trying to delay or prevent. And then they also need to have their cognition needs to be anywhere from cognitively intact to mild cognitive impairment. And we do have a slight adaptation to capable in the way we ask questions. So if there are individuals that have mild cognitive impairment or early stage dementia, they can still participate in capable. The clinicians are being taught how to adapt their questions for that population. We have found that the benefits are still there for that population because they are still able to learn new skills. Their disease process hasn't advanced far enough to where they can't learn new skills. So if we adapt the way we ask questions, they can still participate in the capable program. Next slide. So within this program, what makes it different from traditional home care as far as an occupational therapist and a registered nurse going in for traditional home care is that the client is truly setting all of their goals. The person they are problem solving and brainstorming with the clinicians. They are putting together action plans, meaning they are acknowledging, I am going to practice these things between our visits. And we're providing them handouts that give them the information that they're going to practice, that they've picked out, and they're going to practice between visits. They're actively trying new equipment, new strategies. Maybe it's some compensatory techniques to doing an activity differently. And they're actively doing these things and trying these things between visits. So then the ultimate result is they're actively achieving their goals. They're able to meet the goal of being able to go down the stairs with less fear of falling, being able to bathe themselves more independently so they don't have to ask their daughter or son to come in and double check to make sure their quality of their bathing is good. They're actively achieving these goals, and it's their strategies that they're implementing and trying in order to achieve these goals. Next slide. So this is an example of a client who participated in Capable. Mrs. R had advanced arthritis and lung disease, and she worked with her team to set a goal. Next slide. Next slide. She set a goal of being able to play the piano with less pain. So we requested that the handy worker add an light on easier. The light was already there. However, she couldn't reach the string to turn it on. So they added an extension cord to the light so she could turn it on easier. Next. They also elevated the height of her piano bench. This allowed her to get on and off of the bench easier. Next slide. And then they also provided her with some compression gloves and a back brace. This allowed her some pain relief in her back along with her hands. What's great about this and what we look forward to in the Capable program is when people take the strategies that we have provided and that we've discussed together and they generalize them over to other activities. Mrs. R started wearing her compression gloves and this back brace during other activities, doing her laundry, meal preparation, those types of things where she was having pain and she was like, you know what? If it helps here, I bet it will help in other areas of my life. So she started wearing the gloves there. Next slide. And overall, Mrs. R felt like she had less pain while playing the piano, so she met her goal. Along with a few other things she was able to meet by decreasing pain, was being able to have manage her laundry and cooking with less pain as well. Next slide. So capable, it intersects a lot of different places in people's lives. We address their home. We're able to help them. We are adapting the environment to them. We're crossing sectors with healthcare services. So, especially with our nurses, we are really encouraging our clients to communicate more with their different healthcare services, communicating with all their different specialty doctors, and providing other resources in the community to help support the client. We work a lot with our local fire departments. Those lift assist calls that our local fire departments get often, we're working with them to try to help prevent those falls and help decrease those calls that they're getting by providing more fall prevention recommendations within the home. So as you can see here, we're really addressing a lot of different areas within people's lives. So it's not just a siloed approach. We are helping people in multiple areas. So it is more of a holistic approach, and we're making impact in multiple areas. Next slide. So here's the research. What's the benefit of this? The client's benefits, we have that. We have that they've, are increasing their independence and safety. But what's the healthcare benefit? What we have found in research with our initial pilot that occurred was that those clients that participated in Capable saved our local United States Medicare and Medicaid services money. It saved Medicare about $22,000 over a 2-year period per client by decreasing hospitalizations and ER visits. Medicaid saved an additional $10,000 annually. We also found that the participants felt like their independence had improved. So those activities of daily living, of dressing, bathing, and toileting, those improved by 75%. Their instrumental activities of daily living, which include cooking, cleaning, laundry, medication management, they improved those. They felt like 65% of those clients had improved in those areas. Depression also improved. They used the PHQ-8 score or scale to measure depression, and those scores improved. 53% of the clients had a lower PHQ score at the end of the intervention. And then home hazards improved as well. So almost 78% of the clients had less home hazards after the program. Next slide. And then this here shows the Medicaid cost savings. So as you can see on the left, the control group, the people who did not receive Capable, spent about $2.2 million in healthcare cost compared to the treatment group, $1.4 million. There was one area within the treatment group that did go up, and that was our home health services. So physical therapy is not part of this intervention. And so often we do provide a physical therapy screen at the very beginning to determine if a client needs physical therapy. And if they do present positive for the need for physical therapy, we will make that recommendation. We do not force clients to participate, but we will make that recommendation for them. And so a lot of clients received physical therapy services through home health during this research study because of that positive screen. And so that cost based preventative care. So it doesn't matter that that cost went up because we're still providing resources for decreasing hospitalizations and ER visits. The big cost savings here were by decreasing those ER visits and hospitalizations, but also long-term care. Some other areas that you'll notice here is pharmacy cost went down because we were able to notice they could de-prescribe medicines. Maybe they were receiving two different types of blood pressure medicines, one from a cardiologist and one from a primary care doctor, but they didn't have access to the same records, so they were doubling up. And then that causes, obviously, blood pressure issues. And these are things that the nurse notices during the visits. And so those pharmacy costs went down as well. Next slide. So the difference between capable and traditional disease management. Traditional care, we're looking at a single diagnosis or event. In capable, we're not looking at a single diagnosis or event. We're looking at a holistic picture. It's client driven versus provider driven. We're not going in and telling people what they need to do and educating them based off of what we feel like they need to learn. We're asking them what they want to do. So this here just focuses on how is capable different than traditional medicine. Next slide. As we've mentioned, capable is in Nova Scotia. National Center to find out about this program and how they could potentially bring it to their residents. So we had a meeting with Honorable Barbara Adams, whose background is a physiotherapist. And then they completed, there was a lot more steps between this, I'm sure, within their government. But this was how they involved us. And then they completed a request for proposal and they selected Victorian Order of Nursing to implement capable for a pilot. And so capable is currently in Nova Scotia. They are currently implementing a pilot. And so from our understanding and just the communications we've had with them, it has been very successful thus far. Next slide. So how could you bring capable to Ontario? I have several people here that we believe that you could email about capable and to encourage them to reach out to the Capable National Center, look at our website to determine next steps. They can find all the research on our website as well that supports the cost savings, how it impacts the clients in multiple areas. So as I mentioned before, we have over a decade worth of research and studies on our website that provide the background that is needed to support capable. And so don't hesitate to reach out to your representatives to encourage them to investigate capable, encourage program. Next slide. All right. So we do, even though we are contracted with Johns Hopkins School of Nursing to provide the capable support, we do keep in communications significantly with Dean Sarah Santon, who is the co-founder of Capable. She is still heavily involved in the capable progression and how we scale capable globally. And then this is the rest of our technical support team that helps all of our current sites and our future sites get up and running. I believe that is it.
Well, that's great. Thank you so much. I'm just going to go to the gallery view so I can see everybody. Amanda, are you prepared to take questions from the folks? Because I'm sure there'll be some. Obviously, there are going to be some differences between the US and Canada and the way things would be funded. In the US, it's somewhat of an insurance-based program, and of course, you would want Medicaid to get more involved in that. But in Canada, we have the ability for the provinces to basically incorporate a program like Capable into the Home Care Modernization Initiative. Ontario Health and Ontario Health at Home have embarked on a home care modernization initiative. We include Capable as part of that. The reason is, and those of you who are already getting home care will know this, home care right now in Ontario is a staff-based or program-based program. It is not a client-directed program. So in other words, you can't say to home care, this is how many hours of home care that I need, and this is what I need them for, and have them just decide to give you that. Basically, they decide what you need, which is the opposite of what Capable does. Capable sits down with people and they tell them what they need, and then they act accordingly. So we're trying to get more of a client-directed approach in Ontario, and Capable does provide that. Capable coming in for 4 months would make a huge difference for a lot of people. First of all, the Capable team could determine very quickly, along with the people they're serving, what they might need from home care, which would certainly help the process, because right now, having other people assess you is not exactly a positive experience for a lot of people. So if you've got questions about some of this, one of the reasons SSAO decided to ask Capable to do this presentation was because it's a rehab model. It's not a custodial care model. In other words, it's not a, oh, team might be able to help people to get out of bed by themselves if they have the right equipment. So that's the kind of thing that we're talking about. So if you have questions for Amanda about that, I'm going to look for your hands. I see Karen, you've got your hand up, I think. Do you? No, maybe not. So if you want to go to, I think it is, let me just see, is it React? Yes. If you go to the React button on your phone or your computer, there's a raise hand function that you can just press, and then I can see if you have a question for Amanda. So let me just see, are there questions?
Oh, there it is. Yeah.
No? No questions?
Yeah, I do. Where's the react button? Yeah.
Dale, I think you need to mute.
Oh, sorry.
That's okay. Okay. Anyone who has a question?
While you're thinking, I guess, too, is, you mentioned that we don't go in and just help people do the things. So it's a hands-off program. The clinicians are more consultants in this program. And, we'll often get people asking, like, I need help cleaning my house. I need help organizing. And we'll tell them, like, we won't come in and do that, but we'll definitely support you in that process and maybe provide you with the proper equipment or tools to do that, or even maybe a resource to help support it. So maybe it's a shelving unit to help get things off of the floor so they are more organized, or, people will write goals of wanting to be able to get their finances more organized. So we'll talk about, what kind, do you need a filing system? I have a client right now who needs a filing system, and she came up with the strategy of how she wants to organize her bills. Not me, because if it's her idea, then she's going to follow through. If she didn't have ideas, then I would have provided suggestions as far as, what are your thoughts about this? And she could have said yes, no, or given me feedback. But she had ideas. She just needed confirmation.
Yes.
Another client had fallen down her stairs, and she was paralyzed with fear of going downstairs. And so she lived on her top floor pretty much all day long, every day. She would go downstairs one time. Her family had put her a microwave up there along with the mini fridge.
Wow.
And so they aided that fear in a sense, but we added an additional banister to her stairs. And we talked about making sure she had the lighting on when she was going downstairs, those types of things. And now when I went to see her for my last visit last week, she was like, Amanda, I'm living in my home again. And I said, what a powerful statement you just said out loud. You're living in your home, like the whole home, not just the upstairs. So, and we're pretty much giving people permission to get better and move along, but at their pace and at their recommendations versus being told what to do.
Exactly. And I'm so glad you reinforced that. And so we're having to advocate with them and for them to even get the home care that they need, because the people doing the assessments are not doing it correctly or doing it according to people's
Mhm.
needs. So
Yeah.
we've got two questions. Monique, did you want to ask your question directly to Amanda? You're asking who you can get in touch with, and then I'll go to Melanie. Monique, are you there?
I can.
Go
Um,
ahead.
I think that this whole presentation is quite inspiring, actually. And I would love to have more conversations in regards to, how to make this happen. And I know I'm hearing home care and I'm hearing Ontario Health at Home. This actually for me goes way beyond those requests of help from Ontario Health at Home that, you know, come in, do their thing, great support, great help. Um, but this whole project has another flavor to it and other objectives. And I think it's way bigger than what we could even imagine. Ontario Health at Home is one thing, but the community support services who are already in place in Ottawa and in Ontario, I think that this is a wonderful, wonderful project.
It's a great,
So
great
if I
point.
can speak to someone and try to get my head around, obviously, there's the funding, but how you are presenting things in such a meaningful way was extremely touching. And I don't think that the Ontario Health at Home is the route. And I don't know if anyone from Ontario Health at Home is listening, but I don't think that that's the route that needs to be taken. I think there's another route, and I think it's wonderful.
So I added our email address in the chat, so you can email us. I would be the one you would talk to about it. I think, you understand your community and your resources best. And so for you and I and the team that you want to pull together to brainstorm and problem solve through, that would be ideal as a one-on-one meeting. Because like I said, you know your community best. And so we could talk about that together on who do you think we could bring to the table to share capable with, to talk about like, how can we bring this to our community? Would you be a partner? And that's what we do here at the Capable National Center. That's my job, is to work with inquiring individuals, organizations on how to bring it to their community to serve their residents.
Yes, and just Monique, you're in Ottawa, so you're in the nation's capital, and that means you have access to people like the Minister of Health and other people. So you can certainly also speak to the Minister of Health, their parliamentary secretary, and other people, and mention this. And the reason I say that is because SSAO has written to the Minister of Health, and we've copied the parliamentary secretary to the Prime Minister and a number of other people, including the Quality of Life and Wellness Cabinet Committee Chair and others. So the more they hear the word capable, the better, because we find repetition helps them learn. So we have to keep that up. So Melanie, you have a question? Go ahead.
Yes, I kind of listened to this wearing two hats. One as an aging senior, but also as the parent of a 40 plus year old who has significant physical disabilities, who lives on her own. And how do I keep this going after I am gone? So, and when I think about, what you've said, the three things, like the registered nurse, the occupational therapist, and the handyman in this case for my daughter is her brother. He gets called upon regularly. And yearly, we do that yearly review with the occupational therapist just to find out, what's new that might be useful and helpful. Haven't done the registered nurse. I guess perhaps I'm still staying on top of that stuff in terms of her health needs. So the piece that I'm really interested in, that I'd like to hear more about, is your care partner support specialist, because I'm the care partner in this case. What could that specialist do for me as I age, but also even thinking in terms of my daughter as she ages?
So when this program, the Care Partner Support Specialist is there to provide obviously support to the caregiver or the care partner, so there's an assessment that is completed. The care partner fills out an assessment and they determine what are the things that provides as they provide. So the care partner formulates goals as well. So it's based off of the goals of the care partner on what that support specialist provides. Again, we don't go in with a generic, here's what we're going to give you. It's all based off of the client directed goals. So whatever that care partner's goal is or goals are, the support specialist will provide. What we have found is traditionally it's related to like respite care, community resources, those types of things. But again, it depends on on the person's goals, what they put with that care partner support specialist. One thing that, go ahead.
I was just going to say, so in my case, that goal would be who can help keep the system going when I am no longer there for this individual. And I think, a care partner, sometimes they just totally wear out. So when it comes to seniors, so like who helps then if there are those PSWs that are needed to come in and, agencies it just doesn't cut it. Who helps then with finding those new PSWs that you need? Who helps with ensuring that there's that social connection that continues for that individual?
So I would say, again, it's all dependent on what's available in the community, what resources are available. And that's what the clinicians that are in that specific environment are knowledgeable about, the social workers are knowledgeable about, the OTs, the RNs, to provide those potential resources that you're talking about. So, not knowing your community, they would know the answers to hopefully that, or help you do research or guide you to where to look for those answers. One thing we want to be careful of within the capable model is doing for people. So because we want them to advocate, right? The model's 4 months long and we want them to be able to continue on once they've graduated from the program. So we really encourage people, we'll provide the resources and then we encourage them to reach out and make that connection to try to set up next steps with that community resource.
So as needs change for the individual, after that 4 months, could they come back like maybe a year later and reapply?
It really depends on the funding source. So here in the United States, most of our sites are grant funded. So our insurance systems do not pay for capable yet. We have 2 states that Medicaid waiver does cover it, but the rest of our sites are all grant funded. And so the funding source, along with that individual site, will determine if a client can re-enter. We provide guidance that if they say yes, a client can re-enter, that it needs to be at least a year after they have graduated, and there needs to be a change in status. Meaning,
I was just going to say, I guess it goes back to what you said earlier. The client learns the methodology of solving problems
exactly
over the 4 periods. Fair enough.
Yeah, exactly. So, but there are instances where people need to re-enter because there has been a change. Maybe they've had to have a move, or a spouse has passed away, and so their whole environment and routine has been disturbed. So there are times where they've had a stroke or something medical has happened, and so sometimes there is a need for them to enter the program again, and that's okay. And what I have found from my experience, because I still see clients, is that when those people do enter the program, that problem solving and brainstorming comes back. Like I find that when I start that session where they're problem solving and brainstorming with me, it's more of a conversation versus me leading and coaching them as much. I'm pretty much just writing down the stuff they're talking about, why the problem occurs, and then next to it the solution. And so that's a positive thing to see during those visits.
Yeah, it's what sounds important about this is that it's not a program that contributes to dependency. It's a program that
Correct.
contributes to independence. And essentially, the support specialist would have a much better knowledge, frankly, um, than a lot of the care coordinators we see in Ontario Health at Home, who some of whom seem not to even make referrals to community agencies. That is part of their mandate, but we're not seeing them make referrals as much as they maybe should. So that's another thing that with the community resources who can assist people to
Right.
connect with them. And Melanie, I mean, we all know about building support circles. You know, that could be part of the function of a community agency is building support circles around a person so that there are people to carry that on. So I think that that's important. And I want to go to Barbara. Barbara, you had a good question in the chat. Do you want to ask it of Amanda? Give Barbara a moment to unmute.
Sorry. Well, I don't know if Amanda can answer this because it's more about our situation here. I asked two questions actually, but one was just where will the information from the Nova Scotia pilot go? How will that be shared, and what would be how could we best throughout all of Canada make use to the fact that we do have this pilot in Nova Scotia?
So their information, it'll go wherever they share it. So at the Capable National Center, we do not dictate where people or how people or organizations share their data. It will be 100% up to them. And we are hopeful that they will share it with us once they have the information and have a final report on how their pilot turned out. But I don't have information on how or where it will be shared. I'm
Right, but
hopeful that it will. They did a big media release when they started Capable. Yeah, I know people are following it in their area, so I'm pretty sure they will provide the information once it is available.
and
They
Barbara,
are approaching their second year in the program.
right. Barbara, if I can make a suggestion, we have the Victorian Order of Nurses in Ontario. I think it might be worthwhile to send them an email and just ask them whether there are any plans to partner with Capable for Ontario to make it available and whether they're in touch with the Nova Scotia VON because they might be able to get their hands on the data. So just a
Yeah.
suggestion to write to them maybe. Amanda R., you had a question as well or a comment?
No, I was just mentioning that this program is excellent and I think should be implemented in Ontario and across Canada as well. Thank you.
Yep, there's an endorsement. Yeah, I mean, I think, the issue is that we have nothing but custodial care in Ontario. Whether it's putting people in institutions or whether it's in home care, we have not shifted to a rehabilitative model. And we need to start doing that because I think older people don't want to be treated as, burdens and passive recipients of care. They want to be part of the solution. And so that's why we wanted Amanda to come and talk with us because it's a very different way of thinking about things. And it's a way that that I think older people prefer. So
And
are there other, sorry, Amanda, go
I was
ahead.
just going to mention, you talk about being a burden of care. Often, also, our older adults, they won't acknowledge or talk about being a burden of care, like with their family. They will talk to clinicians who come in and listen, but
Yeah,
they don't bring that concern up and that feeling up to others. I hear it all the time, but they will always say, I wouldn't tell my son or daughter this. One of
right.
my clients' goals one time, it was right before the holidays. I was seeing her from September through January, I think was the 4 month period of time that I was working with her. And she said, I don't like going to my daughter's house for the holidays. I go, but I don't like going because I'm worried I'm going to get stuck on her toilet. So I don't eat or drink when I go because I don't need to go to the bathroom. I also don't take my water pills, her Lasix or furosemide, because that encourages her, requires her to go to the bathroom all the time. So she's not taking her medication as prescribed and then is dreading it. And she loves her family, like she likes being with them. So we talked about that. So her goal was to be able to get on and off the toilet without her grandsons having to come and pick her up from the toilet. So we talked about why is it occurring? I simply gave her a foldable toilet frame that she could leave at her daughter's house and they could put it out when she came in order to be able to go to the toilet. And that solved it. But she was not about to tell her daughter about that issue and her concern because she wasn't comfortable doing it. And she didn't want, one, she didn't want her grandsons to see her in that position, but she also didn't want to be a burden constantly asking them to come get her. So a simple solution and someone there to actually listen and her feel comfortable to talk about that changed her experience, for the holiday season that year.
It's really interesting because we hear all the time from older people who don't want to tell their families what their symptoms are because they're afraid that their families will start to consider them for long-term care because those are really most of the only options. The good thing is with a rehab model, your professionals you're involved with are not interested in putting you in long-term care.
No,
And so
opposite.
that makes a huge difference. People feel safer to talk about the symptoms or the problems that they might be having to a professional who doesn't want to put them in long-term care. You talk to a care coordinator about that, you could end up in long-term care a lot faster than you had planned. So a lot of times people are telling us that they're hiding what they actually need from their care coordinators so that they don't get pushed towards long-term care where they don't want to end up. So, yeah. Other questions? Any other? Oh, there's 6 new ones and I've missed them. Okay. So Amanda, we've talked to you. We've talked to, okay. I think Liz. Liz M. Did you want to ask Amanda about the VON in Nova Scotia?
I've just unmuted myself. Can you hear me?
Yes.
Yes.
Yeah. Okay. My only question was to get it right that it was the VON that's doing it in the only place in Canada yet.
Correct. That is correct. The VON is implementing Capable in Nova Scotia, and they are the only agency, and they have support with the local government to implement it.
Right. And then somebody else asked about sharing this model with agencies the Health at Home use. So that would be yes, we should all advocate with the VON to spread the word.
Yeah, absolutely.
In order for
Thank you.
agency to implement Capable, they do have to have a Capable license. So they would go through us to receive a Capable license. And then we share with them how to implement the program. So we have an implementation manual. We have a technical assistance team that provides assistance. And then the clinicians that are providing Capable are trained to provide Capable. So there's about 10 hours of training that's all done self-paced online in order to provide the intervention. So the OTs and RNs both go through that online training to learn how to provide the Capable model. Fran, I see you have your hand up.
Yes, I was just going to comment. I think one of the things I really like about this is the third person involved. That is the person who does the changes in the house, because I think for so many people, well, certainly in Toronto, it's the case that it's very easy to find somebody to rebuild your house, but it's very hard to find somebody to do those little things that would make so much difference to people. And these days, people are also so worried about scammers that the idea of going out and finding somebody to come and put something in your house is really a problem for a lot of older people. So I think this is one of the really great things about your program, and thanks for sharing it all.
You're absolutely right. Having that construction partner, we call it a handy person because a lot of the work are small projects.
Yeah.
We don't have funding for large home remodels. So having that person to follow through and actually implement the work that's needed is huge. I've been an occupational therapist for 20 years, and I've made the recommendations. I think a grab bar would be great here. I've put blue tape up to identify where it could go, but then having someone to actually purchase the grab bar and then install it, it was never done. It wasn't followed through with because the funding wasn't there to support it. So to have that ability within this program to follow through, and we hear that. I was actually just reading a chart this morning from one of our clients that the OT put, the client does the client notice changes in what's going on in her environment and herself since you began the program? And she said, yes. The client said, I didn't actually think you were going to follow through with the stuff that you said you were going to do. I'm shocked that you've actually done the things that you said you were going to do. That's huge. That's impactful, and it gives people hope, right? That things are going to people are going to make changes and actually follow through with what they're saying.
Yeah. That's a big deal because people get let down so often, I think. So
All the time.
I
I mean,
know.
people are let down all the time because they're being told what to do. And then it's such a struggle to get the follow through and to follow up with the resources, or there aren't resources provided, or you aren't confident that you can share your actual concerns and issues because they might push you out the door into long-term care.
Exactly. Rose, just to answer your question, the answer is in the overheads that Amanda gave to us, the people that we need to contact. And contacting your MP to get it started in Canada would also be a good option, okay? Just to answer that question. And we have Allison. I think, Allison, you had a question as well. I'm just going down my list here. Allison, you had a question, I think, in the chat about payment, was it?
There is. It says, do the clients pay anything out of pocket for this service, or is it fully covered under their insurance, USA and in Nova Scotia? So as of right now, the clients do not pay anything out of pocket. In Nova Scotia, it is fully funded through the government and their pilot program. Here in the United States, we only have 2 states that will cover it underneath a certain Medicaid waiver. The rest of our organizations that are licensed capable site are all grant funded. So we do not bill insurance through those grant funded sites. And again, then there's also no payment for that for those clients that are grant funded. The organizations secure funding to support the whole program.
Okay. I can only see the name Druin, but somebody's got their hand up and you're on as Druin. Go ahead. You'll have to unmute.
Okay, am I unmuted?
You are?
Yes.
Go ahead.
Okay, we're looking to, we have a site that will be under Build Canada Homes that we're hoping will be affordable housing for seniors. And since they're looking for mainstreaming construction and so on, are you suggesting that it should be per renter that will be they go through a program to see what they need, or are there are the
Oh, I think you're muted.
You muted again.
Just while she unmutes, basically, I think what she's asking, we have integrated care models here in Ontario like PACE, and in the US, which you're probably familiar with, Amanda. And so with assisted living, we've been pushing to get PACE programs into assisted living, so there's wraparound care and services. Is that something that I think, and please correct me if I'm wrong, if I'm misinterpreting this, but is that something that Capable could be involved in if there was a PACE program in an assisted living um,
So,
place? Yeah.
so I definitely think that the capable methodology can be used within that system. PACE is still a medical directed model. It is all encompassing, meaning they provide all the services, or excuse me, they are supposed to provide all the services that the client or member needs, right? However, again, it's often client-centered and not directed, meaning the client can voice their needs, but they're going to be told what to do next sometimes. So I definitely think the methodology of Capable can be used within that model. And that is something that we are trying to push for here within the Capable National Center. We do have close contacts with several fairly new PACE programs, both here in Colorado and in a couple of other states. And we're trying to get them to become a capable provider so they can provide the capable methodology within their PACE system because it is different.
Yeah, that is good to hear. Here in Canada, we're fortunate because we have pushed for PACE to be client directed, and so far, so good. We've got PACE programs that have started in Halton Region in particular,
Okay.
but also the proposals that are going in from not-for-profits who are leaning towards client directed, which is actually good. So,
That's
Mona,
good.
you've got your hand up, Mona.
I do. Thank you. I'm sorry I came in late. I just wanted to ask you if you're working with the VON, is that what I heard? The Victorian Order of Nurses. Are you yourself a non-for-profit?
Yes, we are a non-for-profit.
I was curious because you were talking about funding and grants and stuff. So yeah.
Yeah, the US has a different system, Mona, so they're sort of stuck with it. So private insurance pays for a lot of things in the US, and trying to get Medicaid to take on new programs and services is a bit difficult. Am I right, Amanda, about that?
It's very, very challenging.
Yeah, so there's a bit of an issue around that. So that's why it's a little bit different, the system. But in Nova Scotia, my understanding is everything is a partnership between the government, the Nova Scotia government, and the Victorian Order of Nurses, so it's completely not for profit. That's what we would go for across Canada. Certainly what we're going for in Ontario when we're talking to the minister, that we want not-for-profit delivery of capable and of PACE programs.
Is PACE non-for-profit? Is that what I understand too then?
PACE is, some of them are for-profit, as I understand it, in the US. But in Canada, all of the PACE programs so far, which have started in Halton Region, they're all not-for-profit.
Okay, that's good.
You'll hear about this more, by the way, in January, if I can put in a plug. Councillor Paul Sharman, who has started the PACE programs and has started PACE Canada, has actually he'll be doing a presentation for us in January to bring us up to date on that. So you'll be. You still have your hand up. Does that mean you have another question? I don't think so.
It's just that I was wondering if we're trying to promote senior housing, affordable housing, whether or not we should also be pushing for this type of an approach that touches on the health and well-being of like if it should be part and parcel, and to what extent that is being looked at by your organization, and not Amanda's, but Social Action.
Yes, what SSAO is doing, because Capable is a 4-month program, And as you heard Amanda say, people can re-enter maybe, but usually not for a year. So what we're pushing for is wraparound program and services in assisted living, especially residences, and also in horizontal NORCs, meaning neighborhoods where there are a high proportion of older adults. We're looking for PACE programs there, but not for profit, not for profit, as in some of the US states. And we would like to see Amanda's program basically kick it off, would be great, because that way you promote independence first. And then if people need additional care and need home care as well, it can go hand in hand with that. So Amanda, if you want to expand on that.
No, I think, it's all depending on where the individual is at the time. Sometimes the home care is needed first and then capable. But I guess it also depends on when you say home care, what does that exactly mean? Like, what does that actually provide? But within the capable model, we're not only looking for right now, what does that individual need, but what would they potentially need for the future? So if they are in a new environment, how can we support them right here and right now, but also for future needs and future preventative needs? So depending on that individual kind of determines what needs to be done first and then follow up secondarily. Does that answer, Trish?
Okay. Yeah. Yes. Trish will be. I'll be in touch with you because we're trying to establish a horizontal NORC, and we may need your guidance on that. How is the individual referred to your program? Who refers them to you?
That's a great question. It really, again, it depends on the site and how it's funded, on how it can be people that are referred. But traditionally, people are referred from primary care doctors, case managers, social workers, individuals that have been in the program in the past. They're our best marketing. They refer people often to the program. We recommend sites go to like senior centers, or where are the individuals that might need capable or be open to listening about capable. We try to engage them in community settings as well.
So people can self-refer also.
They can. Again, it depends on the funding source. So, let's say it is a healthcare, it's an insurance plan that's implementing capable. We couldn't that insurance plan would only see people within their plan. They wouldn't see individuals that are outside their plan or don't have insurance through them. So it really depends on the funding source.
Yeah, so what would be different in Ontario is we would be promoting this as part of home care modernization under Ontario Health at Home. So people self-refer to Ontario Health at Home, and you come in and you talk to a coordinator, and you could tell them that you are interested in taking part in the capable Ontario Health at Home, called the Family Managed Care Program. And people can contact a care coordinator and they can ask to have individualized funding through the Family Managed Home Care Program. So basically, we would want to see capable as another option that people can also access under that program. So it wouldn't be a matter of insurance paying or not paying. It would be a matter of once you're in the Ontario Health at Home program, you have the option. Yeah.
Yep. And that's how,
thank you.
Absolutely. That's how one of our states underneath their Medicaid waiver, that waiver has different options of resources that member can use, and they can pick, yes, I want to use capable, or their care manager or access agency can say, you know what, I think capable would be a great benefit for you. You can access it because it's kind of like another menu option for that member.
Yeah. Elizabeth, did you get to say what you wanted to say? I'm just noticing your comment here. Is Elizabeth Jossam still with us? At any rate, essentially, Elizabeth and her group are doing something we can all do, which is she's going to discuss it with her community and with a number of people in the community. And then they're going to get in touch with Capable and then start putting some heat very likely on their MPPs and local nonprofits and others. So we can take control here a little bit by letting people know about this and telling them that we want it. I know our members are not shy when they decide they want to get going on something. Okay, are there other questions? Anything else anybody wants to ask? Because in that case, thank you so much for inspiring us, Amanda.
Yes. Thank you so much for listening. I love to talk about it.
Yeah, well, it shows. It's really great. And I think, you're probably going to be hearing from a number of people. And we will certainly, as SSAO, we'll certainly keep pushing for it here in Ontario and across Canada. A lot of our members come to these sessions from different parts of Canada as well. So you may also hear from British Columbia, Alberta, or New Brunswick. Some members from New Brunswick have been involved here too. So thank you so much. This has been really inspiring, and we really appreciate you taking the time.
Thank you for the opportunity to share. We appreciate it.
Okay, thank you so much. So that's it, everybody, and enjoy the rest of your afternoon and evening. And we'll see what develops out of this. We're going to do our best to see whether we can get it here. So